Session 4 is on the topic troubleshooting in thrombosis. Over to the chairperson. We'll hand over the coordinates if you want to.
Thank you. That's a very important topic we are going to discuss, troubleshooting in thrombosis. I call upon Dr. Majid for talking on treatment after DVT. Very important. What next? Dr. Majid.
Thank you for inviting me to this great meeting. I have no disclosure. First, anticoagulation after DVT is recommended for 3 months if the patient doesn't have any irreversible risk factor. But if the DVT is large or there are some residual symptoms, it is recommended to extend it to 6 months. And in 40% of these patients, the PTS develops, which is severe in 10%. And the Villalta scale is the best scale to assess PTS because it covers both symptoms and signs. And there are similarities between the signs and symptoms of DVT and PTS. Because of that, it is recommended PTS not diagnosed before 3 months. And there are some risk factors for PTS development. DVT location, I mean proximal or distal one, is not a reliable marker, but the persistence of residual vein thrombosis, which can be assessed by ultrasonography, and also inadequacy of anticoagulation are important factors for development of PTS. And there are some models developed by some studies to predict PTS based on iliac vein involvement, BMI, and civic of Villalta, but they need external validation. And residual vein thrombosis and reflux can be assessed by ultrasonography and has a role in they have a role in the prediction of PTS. And CDT, in comparison with systemic anticoagulation, there is no strong evidence to support that. But for DOAC, they are as effective as and safer than warfarin, and they are associated with lower incidence of residual vein thrombosis. So they may have a better prognosis in terms of PTS development. But rutoside and other herbal medicines, they doesn't work. Venoactive drugs have a role in the management of some symptoms nowadays, according to 2 reviews. Pentoxifylline has been known as an effective drug for venous ulcer, but its effect on other signs and symptoms is not clear. Elastic stocking doesn't work, highly controversial for PTS prevention. I mean, after DVT for prevention of PTS. But if PTS develops, it has a major role in the treatment of symptoms, especially edema, because edema cannot be treated by venous stenting. So according to reviews, compression in acute phase of DVT does not significantly lower PTS incidence, and long stocking in comparison with the below the knee stocking did not provide better protection, and they don't improve quality of life except during the first 9 days. They have some side effects which are not so important, but they have a major role in the treatment of PTS symptoms, especially edema after PTS development. And the last one is the venous stenting introduced by Professor Raju for CVD patients. They have both obstruction and reflux, I mean this valve dysfunction, and it is important to know that venous stenting or treatment of obstruction alone has any effect of the symptoms or the function of the valves. And to address this question, Professor Raju selected 32% of his patients with both of them obstruction and malfunction of the valves, and he saw iliac vein stenting alone significantly improved the clinical outcome in those patients, even though the deep reflux component was left uncorrected. Improvement of pain and ulcer healing was durable, but the effect of swelling, the effect of stenting on swelling is not significant, which can be treated by elastic stocking. So according to reviews, stenting in PTS is useful and can alleviate symptoms, and the edema can be tolerated by the patient if he or she doesn't have other symptoms like pain, and also it can be treated by elastic stocking. Conclusion, ladies and gentlemen, duration of anticoagulation should be based on risk factors and severity of residual symptoms. PTS not diagnosed before 3 months. CAP classification is the most common, but the Villalta scale is the best one for PTS assessment. DUAC are as effective as warfarin or maybe better in terms of PTS development. Venoactive drugs nowadays may have a role in the treatment of some symptoms. Elastic stocking play an important role in the treatment of edema after PTS development, but for PTS prevention, it's not clear. And venous stenting may have a role in those patients with obstruction or stenosis of the iliofemoral veins. Thank you for your attention.
Thank you, Dr. Majid. We'll have questions at the end, so if you can stay with us. I call upon Dr. Sukesh Chandran Nair to speak on dilemmas in thrombosis, dealing with sticky situations. So that's an interesting topic. The slide changer, please.
Right. Thank you. Thank you, sir. Thank you for the opportunity for the Venous Association of India for inviting me. We have a good peer group in India which do a lot of tests related to thrombosis. So some of them are highly revealing for you today. Suppose you have a result which is LA positive, and some of the thrombophilia markers come as positive, that is antithrombin is low, protein C and protein S is low. I can tell you that 90% of them are false positive. 90% of them are false positive. And the reasons for that, the lupus anticoagulation, there is a recommendation for doing the test. There is a phospholipid-based test like APTT is prolonged. Once it is prolonged, it can be because of many reasons, but to show that there is lupus anticoagulant effect has to be demonstrated. That is, you have to do mixing with normal plasma to show that the anticoagulant is also going to make the normal plasma abnormal. Then, of course, the confirmation is you add extra phospholipid and utilize that. None of the labs in our country are doing mixing with normal plasma. None of the labs in our country are doing mixing with normal plasma. Now, the reason for increasing false positivity in lupus anticoagulant is because there is increasing false positivity. Then the issues are patient is on anticoagulation. We are not sure whether the information is provided to the lab to interpret the results. And there's something called the lupus cofactor phenomena. Now, the reason why a lot of false positivity is happening is because they don't do the second step. That is, the anticoagulant effect is not demonstrated, because most of the kits which come for lupus anticoagulant testing, they do not mention in their algorithm the mixing part. So the lab will do the first step, the third step, do the ratio and give the result. They will not be able, they will never demonstrate the anticoagulant effect. So if the patient is on anticoagulation, he's on warfarin, but the results for lupus anticoagulant will come as positive. That's because they don't do the second step. Now, we know that anticoagulants do affect lupus anticoagulant testing, like unfractionated heparin. Sometimes low molecular heparin can also affect. DOACs for sure they will affect. So that information is very important for the lab to have. Vitamin K antagonists, fortunately, they are only reducing the functional activity of the vitamin K dependent factors. So normally you can overcome that by mixing the patient's plasma with normal plasma, which basically means the second step is already happening. So that's what the recommendation. Even if the patient has got an INR of 3, you can still go ahead and do lupus anticoagulant testing. Because, you know, you may have been given a rule that do this test at this particular time, don't do this test at that particular time. So if the patient is on vitamin K antagonists, you can still do lupus anticoagulant testing. Then there's something called the lupus cofactor phenomena. So when you mix the patient's plasma with normal plasma, apparently the normal plasma will provide some cofactor. Maybe it is beta-2-GP1 or maybe it is prothrombin. Therefore, whatever abnormality you got in the first plasma, the abnormality becomes higher after mixing with normal plasma. So that means mixing with normal plasma is very good. So we are talking about abnormal becoming more abnormal. What if a normal can become abnormal and reveal the lupus factor? So how do you overcome this? We have in CMC, so thing is, you know, this is a problem with our country. They are following KIT algorithm. So we have started doing, let's start with mixing. Don't forget, don't start with patient's plasma. Mix with normal plasma, let's start with that. If the mix test is abnormal, then you proceed. So once the data comes out, we'll publish the data and hopefully you will start getting less false positive results, not less. We'll eliminate false positive results for lupus anticoagulant. Now coming to the thrombophilia markers. Thrombophilia markers, we have repeated many thrombophilia markers which have come as positive in your patients. And when we do it, we find an opposite result. So there are a lot of pre-analytical issues, you know, transportation issues, all those issues are there. But how can you overcome this sticky situation? It's very easy. Like lupus anticoagulant needs to be confirmed after 12 weeks to overcome all the transient lupus anticoagulant, you can only confirm a deficiency of a thrombophilia marker if the second sample also is low. So you cannot make a diagnosis of antithrombin deficiency on one test. On a repeat test, if antithrombin is low, then only you can say that this person is antithrombin deficient. And you know, whatever said and done, thrombophilia markers have been proven to be not very useful in management of patients with venous thromboembolism. In fact, our brilliant Dr. Sunil Agarwal, he was probably the first person to stop ordering thrombophilia testing. So, would you have a test which can predict recurrent thrombosis? So, we all know this article, D-dimer, 1 month after stopping anticoagulation, if it is more than 500, you know, this is a beautiful article, all of you have, and it's been reproduced many times. And you know, you stop anticoagulation, 1 month later the patient comes, you do the D-dimer, if the D-dimer is more than 500, continue the anticoagulation. So, that was one particular lesson that was learned from this article. But you know, the patient has to come 1 month later. Then this article came, which was a study was done over 15 years in Norway, where they said that D-dimer at presentation can also predict recurrent thrombosis. So this is the data on patients, you know, good number of patients. So they divided the patient into 4 groups, more than 1,500, not 500. I mean, you know, some people use 500, some use 0.5. Both are, you know, obviously depends on what is nanogram per ml or what. Let's use 500 as a unit. So if the patient comes with more than 500, yes, chance of thrombosis is there. But if the patient belongs to the group more than 1,500 and the other which are really high, so they found that there was a higher incidence of recurrent thrombosis in those who had more than 1,500 D-dimer, especially in the unpro group and incident DVT group. Very high incidence. So it is very useful to do the D-dimer at the time of presentation. So this is you see all the top half is actually the more than 1,500 group and the lower half is the less than 1,500 group. So you have to do D-dimer when the patient comes. Why is D-dimer not being done? Nobody orders a D-dimer. Even, you know, sometimes vascular surgery in our hospital, pulmonary medicine in our hospital, rheumatology, they don't order a D-dimer when the patient comes with suspected venous thromboembolism. You are denying a patient a chance for preventing recurrent thrombosis. Okay, there is a reason for not ordering D-dimer. It's not easily available. A good D-dimer is not easily available. In fact, an ultrasound or a color Doppler is more easily available than a D-dimer. But things have changed post-COVID. There was a target called D-dimer. It was a deviation, but not a specific target. Now D-dimer is available in our country. Before they start discarding the D-dimer from their labs, please start ordering D-dimer. Yes, they'll discard a lot of machines because after the COVID goes away. So then the other question is, why do a D-dimer? Anyway, it will be quite high, anyway high. But that high you must realize, whether it is 500, 600, 700 or more than 1500. More than 1500, you can benefit the patient by a slightly prolonged anticoagulation. Okay, yesterday Dr. Roy asked me about clot with high HP, therapeutic phlebotomy. But if the patient's white cell count and platelet count goes up high, then it's better to refer to a hematologist. The other information that came out during COVID is that many people were put on anticoagulation and anti-10A levels were being measured. There is something that you need to keep in mind when you measure anti-10A. In certain patients, you cannot use APTT to monitor heparin. You cannot use, like especially when the acute phase reactant is high, it will not respond to APTT. In obstetrics, you cannot use APTT. You have to do anti-10A. Even if you're doing anti-10A or heparin levels for heparin, for monitoring heparin, please understand the sample has to reach the lab within 1 hour. The sample has to be processed within 1 hour. Otherwise, you'll be underestimating the heparin. So that is one good thing that Vellore learned during COVID time. That is, yes, they will tell me that the heparin was given at this time, whether it was Clexane or whether it was unfractured heparin, it was given at this time. The sample was collected between 3 and 5 hours after the dose, and the sample reached the lab at this particular time. So that was important for us to interpret. If that timing, that information is not available, we'll say that aapke haath mein. Now in CMC, anti-10A assay has become so good that we are not worried about it. Patient on Clexane developing bleeding. I think today there was a question for Dr. George Joseph. If the patient develops bleeding on anticoagulation, what do you do? Of course, you stop Clexane. But in our place, when they say that patient needs to be still on anticoagulation, and they call me and say that should we do an anti-10A assay, and we need to still continue anticoagulation, I said that why don't you change to dalteparin? Because dalteparin has lesser bleeding risk compared to enoxaparin. Because of this simple study which was done, which came only as an abstract. They didn't allow the publication to happen. Clexane has higher anti-10A, which is a bleeding risk compared to anti-10A action, anti-2A action, while dalteparin has higher to anti-2A action rather than anti-10A action. So this is some advice that we give our patient. Thank you very much. I took a little extra time.
Thank you, sir. I call upon Dr. Pratap Kumar, thrombophilia in DVT management.
Good afternoon, one and all. I thank Vycon 22 for providing me with this opportunity. My topic today is thrombophilia and DVT. So, as we all know, thrombophilia is nothing but it is an inherent ability of a person to form clots inappropriately. That is the definition of thrombophilia. And the first major thrombophilic disorder was discovered in 1965. That was the antithrombin deficiency. But the most common abnormality is the factor V Leiden mutation. So this is a very important tableau column which shows the congenital, acquired, situational and combined forms of thrombophilia. What we have to understand is that the factor V Leiden mutations, the prothrombin gene mutations, antithrombin deficiency, protein C and protein S, they are all congenital thrombophilias and they are high risk thrombophilias. Whereas some thrombophilias like hyperhomocystinemia, they are classified as low risk thrombophilias because this has an effect on the management of such cases. The basic pathology is between an imbalance between a clot production and a clot breakdown. So all the congenital thrombophilias, there is a decreased clot breakdown, whereas in prothrombin gene mutations, there is a gain of function mutation. There is a prothrombin excess and there is going to be an increased clot production. And this is a very important point. Genetic thrombophilic defects influence the risk of a first episode of thrombosis. For example, if I have a factor V Leiden mutation, the chances of me getting a DVT for the first time, it is influenced by genes. but the subsequent or the recurrent DVT is not influenced by these genetic factors. That is the point of this slide. So as you can see, the prevalence of defects in patients with venous thrombosis, all the congenital thrombophilias that I was talking about, they have a relative risk of around 10%, whereas those with acquired or situational thrombophilias, it is around 5%. And you can see on this slide that the risk of recurrent venous thromboembolism in thrombophilia compared to VTE without a thrombophilic defect, it is reversed. That is the second risk, the risk of developing a recurrent DVT is not influenced by these genetic factors. The other predictors of recurrent VTE are idiopathic VTE, residual DVT, elevated D-dimer levels, age, and sex. So some important points about this antithrombin deficiency: it is the most thrombogenic inheritable thrombophilia, and in protein C deficiency, you must remember that protein C deficiency causes thrombosis when the levels drop below 50%. Protein S deficiency, whenever there is an atypical presentation in any patient, for example a migraine or a mesenteric venous thrombosis or a neonatal porphyria fulminans, suspect protein S deficiency in such cases. So normally, the normal coagulation pathway, it will produce thrombin. So the effect of protein C and protein S is to inactivate factor 5 and 8. So whenever there is a protein C deficiency or a protein S deficiency, this inactivation of factor 5 and 8 does not happen. So that is the basic pathology of any thrombophilic state. So as I already mentioned, factor V Leiden is the most common hereditary hypercoagulable disorder. It was named after the Dutch city of Leiden, and it was discovered by Bertina. And prothrombin gene mutations are very important because the mutations, they cause a 30% increase in the prothrombin levels. Antiphospholipid antibody syndrome is very common in thrombophilia testing, and as already mentioned by my previous speaker, it is based on the clinical criteria as well as the laboratory criteria, and you have a condition which is called as triple positive antiphospholipid antibody syndrome. In that case of a triple positive antibody syndrome, you will have arterial thrombosis as well. So these are the basic cells which are affected in the antiphospholipid antibody syndrome: the endothelial cells, the monocytes, and the platelets. And these are the clinical and the laboratory criteria for antiphospholipid antibody syndrome. The blood test, that is the venom, Russell Viper venom test, which was discussed by my previous speaker, and the APTT is usually prolonged in such cases. And patients with thrombosis, we need to maintain on anticoagulation with an INR of around 3. And anticoagulation is usually long-term in such cases because the risk of thrombosis is 50% at 2 years after discontinuation. And thrombophilia in pregnancy is very important because it can cause abortions, intrauterine fetal deaths, and pregnancy-induced hypertension. And all these factors, they can contribute to the thrombophilia in pregnancy. When do you decide to test a patient with thrombophilia? So these are the guidelines for thrombophilia screening according to the American Venous Forum, which is given in all books. And these are the commonly ordered tests for thrombophilia, especially the factor V Leiden, prothrombin, protein C, and protein S. And this is a very important slide. So the congenital thrombophilias that I was talking about, they all have a propensity to cause venous thrombosis, whereas hyperhomocystinemia and lupus anticoagulants, they have a mixed arterial and venous thrombosis picture. So you have to stratify the thrombophilia into weakly positive or weakly thrombophilic patients and strongly thrombophilic patients. When the age of onset is going to be less than 50 years with a recurrent thrombosis and a positive family history, they are all strongly thrombophilic patients. So do we need to routinely screen all patients with thrombophilia? It is not justified, but the risk of subsequent thrombosis over a 5-year period in men with an idiopathic VTE is 30%. So the screening evaluation for strongly thrombophilic patients should include all these tests, whereas those with weakly thrombophilic states, you must test for factor V, prothrombin, the plasma homocysteine, and for lupus anticoagulants. The timing of testing is also very important. For protein C, S, antithrombin 3 and lupus anticoagulant, you have to wait at least 4 weeks after stopping warfarin, at least 24 hours after stopping rivaroxaban or apixaban, and at least 8 weeks after the most recent miscarriage. But it can be done anytime in cases of genotypic testing for factor V Leiden and prothrombin gene mutations. So as already mentioned, the samples should reach the laboratory within 4 hours, and the algorithms for screening is whenever the DVT is provoked by a trigger, you have no role for testing. But whenever there is an unprovoked DVT or DVT at unusual sites, or it is provoked by a weak trigger with a positive family history or a female in the childbearing age group having a thrombosis, you have to order testing. So what we have to remember that antithrombin 3 deficiency, protein C and protein S, they are not reliable in the presence of acute thrombosis and in the presence of anticoagulation. And the treatment basically is by means of anticoagulants, and there are parenteral and oral anticoagulants. Now this is the clinical scenario. If you have an acute thrombosis, you usually go for anticoagulation for 3 to 6 months. But in the presence of unprovoked thrombosis or a concerning family history with multiple inherited thrombophilias, a life-threatening thrombus in a male sex patient with atypical thrombus location, consider indefinite anticoagulation. And the use of direct oral anticoagulants in inherited thrombophilias has been extensively studied, especially rivaroxaban. It has been studied in antiphospholipid antibody syndrome, in triple positive antiphospholipid antibody syndrome, and they have found that the use of DOACs was associated with a lower 2-year risk of VTE recurrence after anticoagulation discontinuation. And this is the last slide. They also suggested that DOAC use is or can be done in low-risk thrombophilias, especially factor V Leiden and prothrombin gene mutations, but its use in high-risk patients such as the triple positive APS or in the presence of arterial thrombosis is questionable. Thank you for your patient listening.
Thank you. We have the last speaker, Dr. Manish Rawal, speaking on a new entity, that is thrombosis in COVID. Lessons learned. Over to you, Manish.
Good afternoon, my colleagues. Thank you for inviting me for this talk, seniors and my friends. The subject that I'm going to talk about is the outcome of catheter-directed thrombolysis in COVID-19 associated deep vein thrombosis, our experience. So this was a number of cases that we treated during the second wave of COVID, and this was done in association with very esteemed and very good friends, Dr. Sunil Rajendran, Dr. Edwin Stephen, and myself. And it was done at 2 different places. And we analyzed the data, and we had some findings which suggested that, okay, we can manage deep vein thrombosis, COVID or non-COVID associated proximal DVT in a different way. So published evidence of venous thrombotic complications of COVID-19 is lacking. And India, as we know, we had number of cases, or such high number of cases, that we had no tool or no groundwork to prepare us for the study of the incidence of deep vein thrombosis in any way. This case series consists of 29 adult patients who were COVID-19 positive and treated for deep vein thrombosis during the second wave of the COVID-19 pandemic in India. Study was aimed at analyzing demographics of the patient with DVT and the outcome of catheter-directed thrombolysis in COVID-positive patients. We analyzed data of 29 patients who presented with DVT during a 3-month period, who were managed with either CDT plus anticoagulation or with anticoagulation alone. The experience and observations in this case series is shared while stressing on the need for compiling a larger series before drawing a definitive conclusion about the management of COVID-associated DVT. Patients who developed DVT while or after being COVID positive were managed between February and April 2021 at the institution of the first two authors and were included in this retrospective study. Demographic, clinical data, laboratory data, and treatment given were analyzed, and all patients were followed up for 3 months with a Villalta score. There were total of 29 patients, 12 male, 17 female included in this study with a mean age of 47 plus or minus 17 years. Average time of presentation from being COVID positive was 17 plus or minus 3 days, and one patient developed DVT after becoming COVID negative. All but one patient had lower limb involvement, with 42 or 43% having proximal and 57% having distal deep vein thrombosis. All patients with iliofemoral and 2 of femoropopliteal DVT were treated with catheter-directed thrombolysis. Another 15 were managed with anticoagulation alone. No range thrombosis was observed in the thrombolysis group. Overall average Villalta score at 3 months was 10.7 plus or minus 2.1 with a score of 10.58 plus or minus 2.1 in the anticoagulation only group against 10.85 plus or minus 2.3 in the CDT group. This is the table showing, it's a very busy slide, but that reflects on the patients that we treated or included in this study. Again, this is a Villalta score of patients treated with anticoagulation alone and with CDT and anticoagulation. So what I wanted to talk about or discuss about, I don't know, in first wave or the second wave, we started seeing a bigger number of patients during the second wave, having deep vein thrombosis, proximal deep vein thrombosis, having complications of proximal pulmonary embolism and many other thrombotic events. So we understood that considering the use of CDT for all with COVID associated DVT, iliofemoral DVT, and those with femoropopliteal DVT who have significant edema or impending venous gangrene, if the bleeding risk is within acceptable limits, these patients can be offered CDT. We have a specific way of doing catheter-directed thrombolysis and the thromboaspiration. The technique has been developed by, in association with many colleagues, in association with even Dr. Malay Patel sir. So to conclude, COVID-19 seems to be an additional risk factor in the development of DVT. Outcome of such patients treated by thrombolysis appears to be similar to non-COVID patients. In this observational experience of the authors, we do suggest that CDT could be offered to COVID positive patients with a symptomatic iliofemoral DVT with good outcomes and an acceptable post-interventional Villalta score. We are happy that this study was accepted for publication in Vascular and Endovascular Surgery year 2020. Thank you so much for this opportunity. Thank you.
Thank you for the excellent talks on the speakers. Open to comments and discussions, firstly from my co-panelist.
Question is to the last speaker. Manish. Good afternoon, how are you? I would like to ask you, in what way the DVT in a COVID patient is different from the COVID in other non-COVID patients? DVT in a COVID patient, in what way is it different from DVT in non-COVID patients?
Manish, you are muted.
Clearly, but if I have...
Okay, we hear you now.
COVID patients, there's in situ immunothrombosis. In other words, when the entire endothelium is inflamed. So they are more prone for DVT and even arterial thrombosis. So that's one of the reasons why we advise DVT prophylaxis even in a patient who's asymptomatic in COVID. We've been doing it in Chennai, and the incidence of course DVT is lesser. I wouldn't say it's lesser than non-COVID, lesser. So this is a different pathology altogether. This is what I wanted to tell you.
Yes.
Just a question to the hematologist from CMC Vellore. See, we all saw a lot of COVID-induced thrombosis. Some of them are accidental finding after a couple of weeks, a couple of months later. IVC thrombosis, ileoquine thrombosis. In these kind of cases, how long to give anticoagulants? The same like before, or is anything different in post-COVID patients?
Dr. Sukesh. Yeah.
Sir, we also know that COVID, the D-dimer levels are going to be slightly different from normal people. So nobody has done a study what should be the right cutoff. Arbitrarily, they said maybe 3,000, not 500. So we are not sure about the ideal cutoff for in a COVID situation. So we are lost. That's right. Yes. So, yes. 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 So sir, you can try the NEJM article. Okay, okay, fine. Yeah. Yes. So thing is, we can probably try the NEJM article. After 3 months, you can stop and try D-dimer. Maybe, there's no information. No, not clear. Not clear. Not clear. Not clear. Maybe at the time, after your regular time of recommended anticoagulation, maybe good idea to do a D-dimer. And if the D-dimer is not more than 500, we'll go down. Yes, for sure. We'll go down. But there are some people who the D-dimer doesn't go down. There are some people where the D-dimer doesn't go down. Yes. Yes. That's right. There is, in fact, the cutoff itself is not very clear.
Thank you, Dr. Sukesh. Yeah, probably the answer is indefinite. And Dr. Pranay.
Sir, I would just like to ask you one more question. So there was an excellent talk, sir. So one of your slides, so you had said that...
1 second, doctor. Let me explain. Extended thromboprophylaxis in surgical patients is very, very clear. But extended thromboprophylaxis in medically ill patients is not clear. The FDA has given approval only for apixaban and rivaroxaban for a period of 6 months period. But otherwise, extended thromboprophylaxis in medically ill patients is still under investigation. So this falls under that kind of case. COVID-induced thrombosis comes under medically ill patients.
So one of your slides, Heparin, you had said that APTT is not this thing reliable test to monitor it.
So there's something called laboratory resistance to heparin.
Acute phase reactants are high.
Like factor VIII is like an acute phase reactant. If the factor VIII is very high,
okay, you look at those.
It will bring the APTT down, even in a normal person also. So, I mean, it will be shortened APTT. So, obviously, when you try to give heparin and use APTT, it will not. In fact, the recommendation for COVID, if the patient is on unfractured heparin, was anti-10A assay, not APTT. It was very clear. And sir, medically, as you said, medically, this thing, for example, pregnancy, it is clear. The cutoff is not 500. It is, some places use 600, some people use 3,000. But that also, there is no uniformity.
Yeah. Thank you, Dr. Sukesh. Dr. Majid, are you there?
Hello?
Dr. Majid?
In all the...
Yeah.
In all the COVID patients...
I'll take your question. Dr. Majid?
Yeah, I'm here. Can you hear me, sir?
Yeah, you had shown us that compression garments after DVT do not reduce the incidence of PTS. So what is your current recommendation for compression garments post-DVT?
You mean wraps or just elastic stocking? You're talking about wraps or just elastic stocking?
Yeah, what do you recommend? Should they use it or not use it?
Yeah, we just use elastic stocking for them just below the knee if the patient feels comfort, because we don't have any evidence to support using elastic stocking for all of those DVT patients. Just it depends on the patient itself. If he or she feels comfort with below the knee stocking, we prescribe below the knee. For lung one, I myself, never prescribed the lung for DVT.
Thank you. Last question. Yeah.
In the indifferentiating with the arterial and venous thrombosis, the D dimer was highly increased in all the COVID positive patients. That was my observation. We actually did 9 cases of arterial thrombolysis, catheter-direct thrombolysis, and we had 6 cases, of which 3 were treated with anticoagulants, and the 3 patients came with unlike to see that patient, because of the iliofemoral DVT, they came with gangrene. We did above knee amputation for 3 cases. For other 6 cases, we treated conservatively. Today, actually, my colleague, interventional radiologist, is presenting paper in Goa in the interventional conference.
I thank the speakers and my co-panelists. Thank you.